and then at the end of the talk, I can open up the camera and you can ask any questions you like. It's an update on lipid management, but I just want to give you some sort of background before. Sorry, I should say okay here, and we give you just like a quick background. Probably no one knows this Japanese guy. I unfortunately did not know him before he died a few months ago. It's an Akira Indo. He's a medical innovator, and he's called the father of the statin. And because of him, basically, a lot of people's lives been saved. The good things about his history, it's actually interesting because he started his process of finding out about the statin therapy inspired by the penicillin, the invention of the penicillin. So started his work back in 1965, and during like a few trials, he managed to understand the concept of statin therapy and to reduce the cholesterol production inside the liver. But the good things about his lifeline, when I looked at it, it started his process in 1965, and it took him a long time until 1980 for his medicines to find its way into the companies interested in his work, and they tried to take over and start reducing his invention. And it's until 1987, it was FDA approved. The first statin therapy become available for marketing is called luvastatin. And even after that, up to year 2000, when statin established as an agent, we used to reduce cardiovascular disease. So I was interested in his life, and unfortunately, he died early this year in June the 5th. Now, why cholesterol? Lipids are the major cardiovascular disease risk factors associated with an initial myocardial infarction. Lipid is the most risk that causes cardiovascular event and contribute to 49.2%. Smoking comes second, psychosocial. When you go through the list, even alcohol, no one really talks much about it. And in some literature saying alcohol is beneficial, it still contribute to 6.7%. Now, target LDL goal by atherosclerotic cardiovascular disease risk, we're targeting cholesterol, one, because we think it's causal. So all the studies, observational, epidemiological, Mendelian randomized study, randomized clinical trials, animal experiments, all studies, they conclude LDL is a causal. So LDL causes cardiac event. And the lower the cholesterol, the better. So there's nothing really to say like the lower limit of LDL level. There's no lower limit of LDL level. Always, if you reduce your cholesterol level, the lower, the better. Now, atherosclerosis cardiovascular disease is the leading cause of cardiovascular mortality in Australia. 42,700 deaths in Australia caused by cardiovascular disease. This is 1 in 4 of all deaths. And in fact, it's not only 41%, it's 41% coronary artery disease. It's 66% of that is caused by cardiovascular disease. So that includes stroke and peripheral artery disease. So it's a large number. That's 1 in 4 patients die from cardiovascular disease. We all know this, this chart, and we look at the chart and we assess patients with cardiovascular disease. And I'm not going through the details of this chart, but clearly diabetes and no diabetes, men and women, age, smokers and non-smokers, and then you have total cholesterol to HDL ratio. We're still using total cholesterol to HDL ratio, which is in fact, probably we moved on away from this ratio into LDL only. But that still comes in the chart, and we look at this chart and we estimate the patient risk. Patients with diabetes, they carry a different risk, and we can see more red boxes, meaning those patients at a higher risk of cardiovascular disease. However, when you look at that in details, There's no family history of ischemic heart disease. There's no LDL level. There's no triglyceride level. What about the lipoprotein little a, which is like emerged as a new risk? What about lifestyle? What about obesity, renal impairment? Plus. There's a lot of other risk factors emerged as an important risk factors, and they're still not within this chart. So we are missing something here. Moving into the primary and secondary prevention, what is the primary prevention and what is secondary prevention? So primary prevention, when the target LDL should be under 2.5 millimole per liter. Those patients who never had cardiac events. LDL should be under 1.8 in patients, even like for primary prevention, patients who are heterozygous, familial hypercholesterolemia, or they had a CT scan, showed an elevated calcium score, and with or without obstructive coronary artery disease. Patient with diabetes, that's still considered as a high-risk population. Even for primary prevention, you need to target an LDL level of under 1.8. In the very high-risk population, even they are for primary prevention, we're talking only about primary prevention, still the LDL, probably we need to bring this down to under 1.4 as per guideline. In secondary prevention, the target LDL should be 1.8 in the high-risk population, and it should be under 1.4 millimole per liter in the very high-risk population. And in fact, we're targeting now LDL of under 1 to basically reach that level of plaque regression. Instead of slowing down the progression of plaque buildup, we're trying to achieve plaque regression. That's found its way into the guidelines, the European guidelines for secondary prevention. LDL should be under 1.4. Primary prevention for individual at very high risk still need to be under 1.4, and the high risk LDL level does under 1.8. So high risk under 1.8, very high risk under 1.4. So this is the guideline, European guideline. Acute coronary syndrome setting, the LDL level should be under 1.4, and we should achieve that as soon as possible. So we're talking here about a patient presented with cardiac events. Within 4 to 6 weeks, you need to give them a maximum dose of statin therapy, reassess them in 4 to 6 weeks, add ezetimibe, reassess them in 4 to 6 weeks, and if you have not achieved target LDL of under 1.4, PCSK9 inhibitor should be added. Now, the Australian regulation, PCSK9 cannot be added unless patient on maximum statin therapy on ezetimibe and the LDL in excess of 1.8, unfortunately. But the guideline, the European guideline, we're talking about under 1.4. Now, we talked about the very high risk. What are the very high risk? So documented atherosclerotic cardiovascular disease, clinical or on imaging. So it's not just clinical. This patient never had cardiac event, but you did a CT coronary angiogram and showed a triple vessel disease, high calcium score. That's still a very high risk population. Patient with diabetes, with or without target organ disease. 10 years cardiovascular disease risk, more than 20% on score 2 diabetes or severe kidney disease. So those basically patients at very high risk and should be targeted heavily with LDL target should be under 1.4. Now, the LDL is not just about 1 point test. It's about timeline. So if we're talking about someone has high cholesterol in their 30s, we're expecting that if this patient exposed to high cholesterol over time, that risk will continue to increase. And that's why it's not just about the time point, it's about time of exposure. The more you expose to high cholesterol level, the more likely to have cardiac event later in life. So even like you have high LDL in your 30s, that need to be treated aggressively. Whether we're talking about lifestyle, statin therapy, we'll talk about this in a minute, but your cholesterol should be down. Why is that? Well, the buildup of cholesterol can be at any time. in some studies showed that there's some lipid streaks in the subintimal area started when induct babies is still in utero. So that can start anytime, and the buildup of plaque can be anytime. If you don't treat that, the buildup of plaque will continue to increase until lead to a STEMI or non-STEMI. And that's or a stroke or peripheral vascular disease. So regardless, that plaque buildup will continue unless you control your cholesterol level. Now, to show you the difference between vulnerable plaque treated and untreated, the untreated plaque, you have microchannels, you have cholesterol crystals, you have macrophages, the lipid pool is huge, and the fibrous cap, if you look at the fibrous cap, is this is a vulnerable plaque that can rupture time. That fibrous cap, very thin, and that can rupture and lead to cardiac event. By giving statin therapy or intensive lipid lowering treatments, the cap will become thick, the lipid pool will become small, and the macrophages reduce in number, the inflammation gets better, and in this setting, this plaque, although it's there, but it's stable. It's not going to rupture. It may cause angina if the lumen is smaller, but likely to rupture and cause cardiac event. The effect of statin therapy is to reduce the inflammation, reduce the lipid pool, and increase the thickness of the. So target LDL, again, is the long exposure to LDL, the more likely you develop cardiac event. And a reduction by like a 1 millimole reduction in cholesterol level will reduce your risk by approximately 19%. Every 1 millimole reduces the risk of cardiac event by 19%, which is basically, that's quite significant. All studies been for years and years and years, and if not tens of thousands, probably hundreds of thousands of people included in these studies. It all shows the lower the better. The purple tube and the blue one, secondary prevention and primary prevention. So if you look at these studies, they all the lower the better. All these studies showing the lower the better, regardless whatever statin you want to use. So the clinical benefits of lowering LDL appears to be independent of the mechanism by which LDL is lowered. Exercise, lifestyle, statin, any type of therapy you follow, if you lower your cholesterol level, you get the benefit. And that's also shown in the Mendelian randomization studies. This is patients followed up for 52 years. The median follow-up was 52 years. Once again, it's showing the lower, the better. There is no bottom line. And I hate it when someone comes to me and say, well, my doctor says my cholesterol is too low, so you don't need to take an 80 milligram of atorvastatin or 40 milligram of rosuvastatin. And these are patients who had cardiac event. Well, that's not true. The lower, the better, and you need to keep your cholesterol down. The consistent long-term reduction of LDL reduces the risk of atherosclerotic cardiovascular disease event. Consistent. And in next few slides, I'll show you compliance is quite important, and keeping patients under the LDL under control all time is quite important. These comments came up on the recent European Society of Cardiology Congress, and that's basically talking about getting patients involved in the discussion, in the decision-making. So you sit down with your patient, talk to them. If they come to you and say, well, Dr. Google says that, or the YouTube, a doctor from Europe says that, or a doctor from Sydney, there's a doctor in Sydney, says that cholesterol therapy or statin therapy is not good for you, well, fine, sit down and start talking about it. And I always tell my patient, well, just imagine these cholesterol tablets are vitamins. You spend a lot of money buying some vitamins. There's no data behind vitamins, but these are statin therapy and all documented in the literatures. There is a huge benefit and will prolong your life. So you sit down and have a bit of talk And I think that's hopefully you can break through. Although a lot of patients will come back with some side effects and muscle aches and pain. And I always tell them to take some magnesium and CoQ10, which sometimes can be helpful. Refer patients to trustworthy materials to aid understanding, not Dr. Google, and collaboration with patient to determine therapy and follow-up plan. There is some sort of like programs and some apps that can also help showing the patients. Well, they're saying seeing is believing, although that sort of statement may not be true all the time, but a patient do believe when they see something, so need to show them something. And the goal is to keep cumulative exposure to LDL below the target level, and that can be personalized, different from one patient to another. In Australia, we're still working with the under 1.8 millimole per liter, although all the guidelines in Europe has moved to 1.4 or even below 1 millimole per liter. Unfortunately, we're still behind, but also the statement comes up with the guidelines says that no level of LDL below which benefit ceases or harm occurs has been defined. Unfortunately, and I promised you to show you this slide, which is, that's an unfortunate, but this is a combined, it's a task that basically we should take responsibility of, and patient probably share that responsibility, but we can't really blame patient for everything. Unfortunately, half of our patients did not reach target LDL of under 1.8. Primary and secondary prevention, and that's shown in a lot of study, and that's to do part of it in like compliance, and some of them basically they don't want to. If we improve like 20% improvement, not 100% improvement, but if 20% improvement in cardiovascular medication adherence associated with a significant reduction in risk of cardiovascular disease, and once again that's shown in some good studies to follow, and also reduces 12% reduces in mortality. Now, moving on, how are we going to do that? We talked about lifestyle, exercise. We talked about statin could be an option, but there are some other medications available in the market, and I'll try to be as short as possible. And as Dr. Media suggested that we don't talk about BACHA here, unfortunately, eat heart-healthy foods is the first point in 5 lifestyle changes to improve our cholesterol level. And I want you to ignore the 5th point because I'm not a big believer in that, and I can tell you why. So the first thing is I'm not going through the details, but eat heart-healthy food. So that's reduced saturated fat, eliminate trans fat, eat food rich in omega-3 fatty acid, which could be BACHA, and increase soluble fiber and add whey protein. The second thing is exercise, and exercise can be anything. This could be a high-intensity interval training, which is probably about 20 minutes. You do of a high intensity, you raise your heart rate to the level that's probably about like 85 to 90% of your maximum predicted. So a brisk daily walk, riding your bike, which I love to work, and probably indoor or outdoor if the weather allows, and playing favorite sport. Quit smoking, that's again important, and there are some facts there. Within 20 minutes of quitting smoking, your blood pressure and heart rate recover from the cigarette-induced spike. I'm not sure how much you believe of that, but this is what's recommended. And the low weight. If you carry too much weight, you need to start losing weight. The aim for BMI is around 25, but I believe in under. I believe in 23.5 as the Asian maximum BMI recommended. So 23.5 of body mass index. Well, they're saying that drinking alcohol in moderation, again, within the same line, within the statement, but the benefits aren't strong enough to recommend alcohol for anyone who doesn't already drink. So there is no benefit from drinking alcohol, zero benefit. And also it carries the risk of cardiovascular disease, as I showed in the early slide. So drinking alcohol is not recommended. How do we get there? So now we've talked about lifestyle, but what about medications? So patients need medicines to control their risk factors, and we talked about primary and secondary. So you start with the maximum tolerated dose of statin. We prefer the high potency statin. What is the high potency statin? Rosuvastatin is the most potent. Atorvastatin comes second. Simvastatin comes third. Luvastatin is basically not the best, but those who are intolerant to first three, maybe you go with the luvastatin, which is an old statin therapy. I do not use that often. If the LDL target was not achieved, and again, don't wait too long, 4 to 6 weeks max, you add ezetimibe, 10 milligrams standard dose. And I'll show you in the next few slides how this works. And if the target LDL was not achieved, you move into PCSK9 target therapy. And there's a 2 type of medications available in the market these days. So escalate therapy. Start with assessing patient risk, extremely high, very high, start on statin, ezetimibe. You can sometimes start with the combination therapy if you think the patient is extremely high risk of cardiovascular disease. And then you add the PCSK9 inhibitor on top to achieve target LDL level of under 1.4. Now, escalating therapy based on patient's LDL level, and we can see it clearly if you start with moderate intensity statin, probably you're able to reduce LDL level by 30%. You change into high intensity, you add the ezetimibe, and you go into the PCSK9. And the maximum so far shown in this study is that we can achieve 85% reduction in LDL level by escalating therapy. And this slide is just to show you as where this medication works. So statin works inside the liver on the HMG CR, and it basically reduces the production of cholesterol in the liver. Most of these medications works that way. So statin reduces the production of cholesterol in the liver.
Yeah.
Okay. Yeah. Do I keep going or yeah? Well, ezetimibe reduces the absorption of cholesterol from the bowel, by which the amount of cholesterol drops in the liver, and that upregulates the LDL receptors and captures more LDL particles from the circulation. Well, the PCSK9 works in a different way. The PCSK9 inhibitor is a monoclonal antibody. It basically attached to, I'll show the next slide, it's attached to the receptor. The PCSK9 attaches to the LDL receptor and lead to lysosomal degradation, and that will reduce the number of LDL receptor on the surface of the liver. What the monoclonal antibody does, it basically acts against the PCSK9 inhibitor, reduces the amount of PCSK9 inhibitor, and that will upregulate the receptors on the surface of the liver. So that's basically what the PCSK9 monoclonal antibodies and that's how they work. Well, what about the mRNA, the messenger RNA, PCSK9, which is basically small interfering RNA, does? This is reduce the production of, so it interferes with the synthesis of the PCSK9. So it's not an antibody, it actually reduces the production, which that's how it works for longer period, and it is quite effective, and you don't need to give it every 2 weeks like what we do with the monoclonal antibody, and I will show you in the next few slides. These are the largest studies done on the PCSK9 inhibitors. It basically the Fourier and the Odyssey, and clearly showing that cardiovascular death, MI, stroke, coronary revascularization, or hospital admission has significantly reduced by approximately 15%, whether you use the evolocumab or the alirocumab. Both of them are PCSK9 inhibitors. What's available now in Australia is the evolocumab. Alirocumab is not available anymore. So clearly showing a significant reduction in cardiovascular death. It's called Repatha. This is the evolocumab, and we can see within 4 weeks, the LDL can be reduced by close to 59%. And that's a significant reduction in LDL level. And with the combination of other therapies and lifestyle changes, that can be even more, and that can reach about 84%. But we can see the reduction of LDL that can be maintained with frequent injections, and Repatha can be given every 2 weeks. What about the Repatha reduces risk of cardiovascular event by 24% in the post-MI? So this is in patients who had an MI recently, and you start on the statin therapy, ezetimibe, and on top of that, you give them Repatha. The risk of cardiovascular event can be reduced by 24%, and that's relative risk reduction, which is quite significant. So that's the Repatha, which is the monoclonal antibody, PCSK9 monoclonal antibody. What about the inclisiran, Litvio? That's also available in Australia, and it is different. This is a small interfering RNA therapy. It also targets the production of the PCSK9 and reduces the LDL level significantly by approximately 51%. It's a double-strand, small interfering RNA, and it has a small particle here, a small part that allows the structure to disappear. It's taken by the liver within 48 hours. So it means that you give the injection to the patient, the actual drug stays in the circulation for under 48 hours, but the effect lasts for 6 months. It's quite interesting. And there's a lot of drugs now using this technique as a small interfering RNA, using this technique to improve compliance, because you give one injection every 6 months, and some drugs you give one injections a year, and that's it. Basically, compliance will be perfect, and you reach your target without any major problem. So Litvio is available in the market, and you can be used with statin and ezetimibe if the LDL level is still in excess of 1.8 millimole per liter. Can be used mainly for secondary prevention, but also in heterozygous familial hypercholesterolemia or a very high risk population. It's given 2 doses a year, but after the first dose, you need to give the second dose at 3 months and then every 6 months. Subcutaneous, 284 milligrams, standard dose, 1.5 mils, and it needs to be given by the health care professional. And the reason why I'm saying it needs to be given by the healthcare professional, a few days ago, I had 2 patients from their local doctors. The doctors told them, no, you can take the injection yourself. The answer is no. Those patients need to come to you, or they go to the cardiologist and have the injections given by a healthcare professionals in the clinic. The needle is quite expensive. It's $3,500 per needle. So need to be given carefully by the healthcare professional. The first one after 3 months, and then every 6 months. So when you look at compliance, so if you look at the pills only, you take every day. But when it comes to the monoclonal antibody, you give one every 2 weeks. That's the Repatha. Every 2 weeks, you give one injection. But when it comes to the Litvio, you give one injection every 6 months. So just imagine compliance here. It's really a good technology, and I think a lot of companies moving on into this. With the Litvio, we can see the reduction in LDL level can be achieved quickly. So the first visit when the patient comes at 3 months, the cholesterol level, LDL level is already down. And when they come to the next dose, it goes up a little and then comes down. So generally speaking, adding Litvio as an injection on top of statin therapy and lifestyle changes and ezetimibe managed to reduce cholesterol nicely by 50.7%. And that can be over time. So it's not just about these points, it's actually the 50.5% reduction in LDL level maintained over time. With the use of PCSK9 inhibitors or Ligvio or Repatha, most patients, like 86.8% of patients, achieve target LDL of under 1.4. So that's significant. If you look at 1.8 here, 86.8% can achieve the target by giving them, whether you go with Repatha or Ligvio, I don't have any difference in between. But those who can achieve under 1.3, that's 74.6%. So it's quite powerful drug, and compliance is not an issue. I will skip this slide because basically that's, just to go quick, over 6.8 years following these studies, they showed that most patients maintained the low LDL level, which is great. And I think that's to do with compliance and easy use. In terms of safety, there's no issues apart from the side. Sometimes you have a reaction to the drug at the site of injections. Otherwise, there's no major safety issues. And they looked at a subgroup in the placebo group, and they found that the response to statin therapy and ezetimibe, sometimes that can be, there's a bit of variability. So some patients, basically they went the wrong way, and the cholesterol level went up, or the LDL level went up. But that never happened within the treatment arm, which is quite interesting. We treat patients with statin and ezetimibe, and we think they're doing well, but in some cases, the cholesterol go the other way around. So I think PCSK9 inhibitor at some stage will become a standard therapy for almost everyone, but at this stage, it's quite expensive, and we may not be able to. Now, we're moving on into what else available and what's in the pipeline we think that's coming. And we'll spend a few minutes talking about some of the drugs that will hopefully become available in the market soon. And one of them is very, very close to become available. It's called bempedoic acid. So the bempedoic acid, it works the same site where the statin works. It actually works to reduce the cholesterol production inside the liver. It works upstream of statin in the same pathway. It doesn't have the same side effect as the statin. So theoretically, should not have the same risk of myopathy and hyperglycemia as a statin. It's still not available in the market. It's approved by TGA approved in America and in some European countries, but still not available. And bempedoic acid reduces the level of LDL by approximately 20%. It will become available at some stage, hopefully within the next few years. Now, the other topic I wanted to talk about, which I think is very important because that's will become available soon, as there's some sort of therapies will become available for the lipoprotein little a. So lipoprotein little a, what we believe is the most atherogenic particle that lead to cardiovascular event. It was found to increase 2.9-fold increase of aortic valve calcification, increase the risk of MI, increase risk of heart failure, ischemic stroke, and all atherosclerotic event, if you like. And that basically the elevated lipoprotein A can lead to these atherosclerotic problems. The problem that with lipoprotein little a, and we haven't been really quite active to measure it, one is not on the PBS, so you need to pay $25, $30. And second, there is no treatment. There is no therapy. However, the guideline did mention that the lipoprotein little a measurement should be considered in every patient at high risk at least once in the lifetime. One, to assess patient risk, because it may actually give you an indication that this patient probably at higher risk of cardiovascular event. And second, there is a therapy coming. There's a drug called lipid, which is an extended duration, short interfering RNA targeting lipoprotein A. That's still under the manufacturing. They're trying, I think that's phase 1 or phase 2 at the moment. And it's found that the use of lipodystrophin reduces the lipoprotein little a significantly. It's a single injection a year. So you give the injection, the LP little a drops, and that continues for the whole year, which is interesting. One injection a year drops your lipoprotein little a and reduces your risk of cardiovascular disease. And as I said before, the short RNA technique, the particle or the injection we give the patient, it doesn't stay in the circulation long enough. It just stays for 48 hours, get absorbed, get taken by the liver, disappears from the circulation. The effect continues for the whole year. And that's the new technology now. Most of the companies, the drug companies, trying to get hold of, and hopefully we'll have more and more of these drugs become available. The other drug that's available in the market now, and it is on the PBS, and it is TGA approved, called Vascepa. And the Vascepa is to treat triglyceride. So it's mainly for those patients who are at high risk of cardiovascular disease, and their triglyceride level is still elevated despite using, whether you use a Gemfibrozil or use fenofibrate. If the triglyceride is still in excess of 1.7 millimole per liter, you can prescribe Vascepa. It is available. It's found to be effective in terms of reduction of cardiovascular event, significant nicely by about 25%. So, it's effective across most like conditions or subgroups. So it is available, and I would encourage every patient, if they have every doctors to prescribe it, if the triglyceride elevated despite other management. How does it work? There's a different way of how Vascepa works, or the icosapent ethyl. It, by reducing the circulating triglyceride, works as an antiplatelet aggregation effect, works as an anti-inflammatory, and there's a different way, but it is effective in terms of reducing cardiovascular event. The other drug that will...
العفو دكتور علي, أتوقع دقيقة ونبدي لك Q&A. What do you think?
Yeah, no, I think I'm finished here, and then with the Q&A, there is case presentation, so I can ask a few questions. Yeah, that should be fun. I'll be there soon.
All
right. So this is probably going to be the last slide, which is the plozasiran. So plozasiran is used for mixed hyperlipidemia, and it's mainly for triglyceride. Again, watch the scope. This patient, this drug will become available hopefully soon. Again, uses the same technology, which is a small interfering RNA technique, and can be given every 6 months. Not available yet, it's still phase 2. So the presentation, in terms of presentation, finished. But I will present one case here, maybe, and leave the second case so we can go for a Q&A. So just to summarize, so this patient, for example, had an ST elevation myocardial infarction, had a stent put into his left anterior descending arteries. He had a PCI, he got a rheumatoid arthritis, hypertension, the current LDL level, he's on atorvastatin, ezetimibe 10 milligram, and his LDL level is still elevated. So what we do here, do we change the atorvastatin to rosuvastatin? Well, yes, you can do that. Or we can increase the dose of the atorvastatin. You can contact the specialist as to prescribe PCSK9 here in Australia. You have to get an authority from the consultant cardiologist. That can be just a phone call, or you refer the patient to the cardiologist. So that's what we do here. And by adding the PCSK9 inhibitor, by intensifying therapy, hopefully LDL will drop. But if the LDL is still higher than 1.9, you need to go into the PCSK9 inhibitor, trying to bring his cholesterol down. So this is the PCS criteria. And I think I will probably stop here and open up the floor for any questions.
شكرا جزيلا دكتور علي. الوقت مشى على السريع.
40 minutes. That's not too bad.
presentation is very nice, very good information. Please, anyone have a question, they can raise their hand or they can put it in the chat.
دكتور أحمد يعني نحكي له ونكتب الأسئلة.
تقدر تتكلم دكتور. عرف عن نفسك
العفو. مسلم الأسئلة.
أهلا وسهلا دكتور.
يعني أهلا بكم دكتور. مشكورين على هاي البرزنتيشن دكتور علي، حقيقة مفيدة جدا. couple of questions if you don't mind. My first question is why the LDL level in Australia is higher than Europe? The evidence in Europe better that if we drop it down lower than 1.8 and like similar to Europe. This is my first question. My second question, we often hear the lower is better, especially from the cardiology colleague. But we all know that cholesterol is integrated in synthesis almost all endocrine hormone in the body. And there's a pile of evidence lower cholesterol is not without risk. In elderly, they increase risk of early dementia. And there's a pile of evidence now, the lower the cholesterol also increases risk of cancer, especially lung cancer. If there's any level that we should think not to drop it further, or we better wean down the level of anti-cholesterol medication? Thank you.
Excellent question. So to answer the first question, when you talk about the guidelines, the European guidelines always comes before the Australian guidelines. We unfortunately always 2 years to follow. It doesn't mean that in Australia, if we stay under 1.8, it means that we are not following the guideline. We love to have the 1.4, but our guideline always about 2 to 3 years after the European and the American guideline. So we're still able to target. So that's number one. The number two, not number two question, still about the guidelines. The 1.8 is to do with the PCSK9 use. And that's basically, one, the drug is quite expensive and the government's put that sort of restrictions. If the LDL level in excess of 1.8, yes, it's start on the PCSK9 inhibitors. But if it's 1.8 or below, no, you can't do that. Not because there is no benefit by dropping the LDL level under 1.8, but there is cost, and it's probably what they think, the government thinks that it's not a cost effective. But the guidelines in Europe has moved, and now they recommend the LDL level to be under 1.4, and that's what we go with. And the studies showed, to answer your question, the second question, all the cardiovascular studies showed that if you're able to bring your LDL level to under 1 millimole per liter, you will achieve a plaque regression. So it's not just slow down the progression, you can achieve plaque regression. And when we talk about some studies showing there's an increased risk of cancer, you need the LDL for the hormones or the glands to function. Now, what are we talking about? Are we talking about an LDL of 2 or 3 that you need to keep, or are you talking about an LDL probably of 0.5? If you give me a number, probably I can give you an answer. But I don't think there is a number. If you're able to bring the LDL level to the lower, the better in terms of reducing risk of cardiovascular event. When you talk about dementia, I don't think there is a strong, strong study in a large population connecting dementia to low LDL level or to use of cholesterol. Yes, there is some reports, but I don't believe there is a strong connection between the two. And once again, it's sometimes you need to individualize therapy. So if patients have been on some statin therapy and they get some muscle aches and pain, or they have some liver issues, or they have what they think it's dementia related, that's an individualized therapy. But when we talk about larger studies, it's a larger studies, and all the studies showing the lower, the better. If that's at some stage change, if you want to individualize your therapy or treatment, I don't think that's available so far. We're still working with large studies. That would be my answer. Does that answer your question, Muslim?
Yeah, well, so I understand there is no level that we should think about, okay, we stop there, not to keep going with, aggressive treatment. We maybe cut down the medication. From your side, like cardiology point of view, there's no level that we should think about. Yes, stop here. Yes.
Yeah, absolutely. There is no level that benefits. There's no low level, or there's a too low that benefits ceases. So you have to continue lowering the LDL level to the level that the patient can tolerate. So under 1, I would love to have an LDL level of under 1.
Okay, thank you.
No worries.
شكرا دكتور مسلم. شكرا دكتور علي. هل من سؤال آخر؟ ماكو بالشات.
Yes, Dr. Issam, this is Dr. Media. Just a question about Dr. Ali, in regard about diet. Intermittent fasting, does it have positive or negative effect on the cholesterol and LDL specifically?
That's a very good question. So intermittent fasting accompanied by exercise has a positive impact on LDL level. Again, you need to be careful with what type of fasting. If you're talking about Ramadan fasting and the bad habits we all have to eat lots of sweets after we break our fast, that's terrible. So we need to talk about intermittent fasting for the purpose of bringing your LDL down. So the answer is yes, intermittent fasting is helpful. And if you do intermittent fasting, for example, at the 12 hours or 14 hours, and you do it twice a week, and if you do some type of high intensity interval training at the end of your hours of fasting, that will add even more benefit.
Sorry, does that mean before you break your fasting, you do your exercise?
That is true. That is true. Okay. So you fast for the 12 hours. Let's say you start your fasting from 8 p.m. and you're just about to break your fasting at 12 midday next day. Between 11 and 12, you can do some level of exercise. And that exercise can be in a high intensity interval training. So you do jump on the spot, you do like a skipping rope, you go for running or brisk walking or cycling, that type of exercise on top of, it's just like you increase your ketones, and ketones by itself is an appetite suppressor. So that goes and suppresses your appetite center and reduces your eating habit. So by the time you break a fast, you feel like, oh, I don't want to eat much, so you eat little. So it helps to reduce LDL, it helps to reduce weight, and it helps to improve your fitness as well. So yeah, that's the high intensity interval training.
Great, thank you.
Thanks.
شكرا دكتور ميديا.
دكتور عصام.
نعم دكتور أحمد.
تسمح لي أنا بكم تعليق؟
أي تفضل دكتور.
نعم. Dr. Ali, thank you very much for the excellent comprehensive presentation. I have a few comments and 2 questions. The first comment is I love always focusing on the anti-inflammatory properties of the statin, both in the setting of coronary events and the trend now toward inflammation and immune reactions in the pathogenesis there. So I think statins helps also not in the lipid lowering process, but in the anti-inflammatory effect by affecting the adhesion molecules, chemokines, all the recruitment of the inflammation. That's one thing. This is very important and to use them. And on this line, I think a deranged LFTs is not, we don't consider it as a contraindication to use the statin. And in fact, the deranged LFTs related to statin, it's a modest elevation and it's dose dependent, usually doesn't affect the synthetic function, and it affects the transaminases, the ALT and AST. And we don't stop the statin with the good and appropriate indication when there is cirrhosis, when there is hepatitis C, when there is what we call it now metabolic derangement related fatty liver disease. So LFT derangement is not a contraindication. Now, Dr. Ali, the questions are 2. First of all, there are some modest agents in the lipid lowering process, including the niacin, the vitamin B3, and including the sequestration, the agent which are used. Do you think that adding them to the statins or to the ezetimibe would be of help? That's the first question. The second question is about familial dyslipidemia and the range of LDL and the spectrum of lipid lowering agent to use.
Yeah, excellent. So I did say in my first few slides, whatever medication you want to use to reduce your cholesterol level, your LDL level, there's no problem. But as you said, why we're starting on statin therapy, because we believe after the cardiac event, or even in the primary prevention in patients with high risk, statin has not only the effect on the LDL level, it has the anti-inflammatory effect. It changes the content of the plaque, it also changes the, as I mentioned, the fibrous cap. It makes it thicker, and that thick fibrous cap will reduce your risk of fracturing plaque and causing cardiac event. So it's not just about reducing the level of LDL, it has that sort of anti-inflammatories. Any other way of reducing your cholesterol level, whether you use Constrand or any other measures, you're welcome to use. Are they going to be quite effective in reducing the LDL level? We don't believe so. As lifestyle is also good. And it's also not just reduces your cholesterol level, it's actually improving your fitness and improve your cardiovascular fitness. But the problem is with the lifestyle in general, so that's exercise and diet, it was found to be effective only by 10%. So it reduces your LDL level by only 10%. And that's why statins become the backbone of treating LDL level. And now the PCSK9, when it's become available, we basically try to bring LDL even further down. So I hope that answers your first question. And the second question was about just remind me the second question. I got distracted a little bit.
The familial dyslipidemia.
Oh, yeah, sorry.
The range of LDL you want to. Is
yeah.
It the same? Yeah.
So the familial dyslipidemia, which I also showed in the initial slides, so basically considered within the very high risk population. So the very high risk population, familial hypercholesterolemia, if you talk about heterozygous, so the heterozygous familial hypercholesterolemia, that's considered a very high risk population and they need to be treated. And the LDL target should be under 1.8 at least, if not under 1.4. And the familial hypercholesterolemia, you can treat with the PCSK9 inhibitor if the statin therapy failed, regardless whether you documented coronary artery disease or not. Let's say if you have a cholesterol of 11 and you've done a genetic study and found to have a heterozygous familial hypercholesterolemia, or use the Dutch lipid score and qualified for doing a genetic study, and the genetic study comes back as being positive. Or even if you use the Dutch lipid score and you score more than 6, then you are qualified to use PCSK9 inhibitor on top of the statin therapy and ezetimibe, regardless whether you had the disease or not. And again, this was discussion with the patient. Some patients disagree with you. And I have one patient who had an LDL level of 7, total cholesterol of 11, and she was 71, and she challenged me. She said, no, I'm not going to take anything unless you prove it to me. And I did a CT coronary angiogram on her, and the CT scan comes back and absolutely normal. So I just raised my hand and say, well, do whatever you like. So that also answers Muslims' questions. It's sometimes about discussion and sometimes about individualized therapy. It's not the whole thing's in the one basket. So you need to sometimes work around that. So the answer is yes, familial hypercholesterolemia. But if you're talking about homozygous familial hypercholesterolemia, those patients, whatever therapy you give them, they will end up with either liver transplant. Some of them, one of my patients had a bypass surgery done in his 15 years of age, and he had a liver transplant at age of 18. That's a homozygous hypercholesterolemia. That's a completely different, and sometimes you end up with a plasmapheresis. So whatever drug you give them, he ended up having a plasmapheresis done every 3 to 6 months. So it's a different type of therapy, and you can just like you do dialysis. So they wash the plasma and get the LDL out. I hope that's answered the question, Dr. Ahmed.
Yes.
دكتور أحمد شكرا.
Thank you very much.
دكتور علي أكو سؤال من الحضور من الأخت شهلاء العاني. One of the adverse reaction of statins is they could induce type 2 diabetes. What about this?
Yeah, and that's mentioned also in the literature. It's just like what Dr. Muslim said. There is a small risk involved. So I have patients who cannot tolerate statin therapy because the liver enzymes went sky high. So she ended up with liver failure in intensive care, and she's absolutely contraindicated. I did challenge her once again with the statin therapy after a number of years, and once again her LLT and AST went up, and we decided to stop and go into PCSK9. The risk of, we talked about dementia. Yes, some people say, well, my memory is not as clear as before. Can I stop them? And we stopped them, we challenged it, and nothing really changed. But maybe, again, that's what we say as an individualized. There is something being reported in the literature that the sugar level can slightly increase, but this is mainly in patients who are either known to have diabetes, or they have borderline diabetes, or they have glucose intolerance. So patient with none of those, and they live a healthy life, it's unlikely the blood sugar will go up.
شكرا دكتور علي. دكتور علي أنا عندي سؤال
تفضل.
كيتو دايت، يعني عندي مريض الكيتو دايت more than a year. His total cholesterol in the 9s and the HDL is 3. CT coronary completely normal, calcium score is 0, no much other risk. And what you will do with such patient? Will you suggest keep going with the keto diet, or you ask to some changes?
Yeah, well, we say that all the time. Keto diet is terrible. The one who put the keto diet died from cardiovascular event, if you know that. The problem with the keto diet, if you're talking about reducing your carbohydrates intake, that's absolutely fine. I have no problem with that. But replacing that with fat, this is terrible. I completely disagree with. So yes, you can have protein and low carbs. Excellent, have no problem. But when you add fat, you substitute carbohydrate with fat. That's what pushes the LDL level up. Now this patient has a calcium score of 0, and you have no coronary artery disease detected on CT angiogram. But what's going to happen in 10 years' time? We talked in this study that's the longer the exposure, the more likely you have buildup of plaque. And I showed you this slide, I think somewhere here. It's all about the plaque buildup over time. So you can show them this slide and just say, well, it's okay now, but what's going to happen over next few years, over next 10, 15 years? With high cholesterol level, there is a higher chance you'll end up with a plaque buildup. So I am against keto diet if you add fat, but if you get rid of the fat, I have no problem with that.
So it's reasonable just to adjust the diet rather than a statin or anything at this stage, because this is the source of the trouble at this stage.
Yeah, exactly. And again, the literature says that fats probably contribute to only 10%. But again, we're talking here about individualized therapy. Most of the cholesterol we have in our body, it comes from carbs. So we eat carbs, we don't burn, the liver will produce fat and store it. You eat fat contribute to only 10% of your LDL level. So it's okay in a way, and that's where the keto diet comes from. But this is not true all the time. And that's why my advice, get rid of the carbs, exercise, and probably eat reasonable amount of fat, not too much.
شكرا دكتور علي.
So, Dr. Ali, اسمح لي, if you don't mind, just one last comment.
Yeah,
on right now you focus on the LDL and the cholesterol. Probably I haven't come across the triglyceride as a major risk factors in particularly diabetic for the coronary events. So I think after LDL, triglyceride, at least in diabetic, is a second most important lipid. What's your comment?
I totally agree, and I did show in my last slides that some therapy is available for triglyceride. The triglyceride should be achieved. It should be under 1.5 millimole per liter. In excess of 1.7, you have to give patients therapy, fenofibrate, gemfibrozil, and I showed the Skiva. So those therapy to reduce risk of cardiovascular event. Triglyceride, it's known to be linked to cardiovascular event. It's known to be linked to microvascular effect, microvascular disease. It's known in patients with diabetic retinopathy, for example, fenofibrate helps to reduce the chance of having retinopathy. So I totally agree with you. And I did mention quickly something about the triglyceride, but I didn't put too much attention to it. But it is a risk, absolutely.
شكرا دكتور علي. أعتقد هل من سؤال آخر؟
Sorry, Dr. Issam, this is media. Just one more comment for Dr. Ali. Dr. Ali, for patients who are non-compliant and they are on statin, they're supposed to be on it daily. But as we know, if the patient is non-compliant, they don't take it maybe once or twice a week. Is there even a point in continuing? Do they get any benefit?
That is very nice questions. They do if you add the ezetimibe. So if you're talking about a patient who is non-compliant because it gives them muscle aches and pain, or they don't remember, if the statin therapy gives them muscle aches and pain, they can take statin therapy on Monday and Thursday, but they have to take the ezetimibe every day. If they are non-compliant because they don't want to take tablets, you can't do much about it, unfortunately. And you need to show them that compliance is important. Now, the indication for the PCSK9 inhibitor, if patient is intolerant, which is an indication. But if they are non-compliant, that doesn't mean they are intolerant. So you can't prescribe the PCSK9 inhibitor because it does improve compliance. So we talk about inclisiran, for example. You give it twice a year, and you give the injections, not the patient themselves. So compliance almost assured. But unfortunately, you can't do that unless the patient is either intolerant or they are on therapy and they cannot achieve target LDL of 1.8. So apart from talking to them, I don't think you can do much.
Thank you.
Any questions from Iraq?
I think we have one of the colleagues already asked question. Dr. Rashada, I think she asked question.
Okay, yeah.
Yep.
أعتقد نختم الويبينار لهذه الليلة.
Doctor, first of all, many thanks for Dr. Ali for the excellent presentation, for you for moderating and managing this. Do you mind if we just announce about our webinar programs with the alternating monthly presentation between a presentation directed to clinician and a community targeting presentation? Do you mind if you just enlighten?
إن شاء الله أي بالتأكيد دكتور أحمد. إحنا حسب المقرر باللجنة العلمية بالاجتماعها الأخير صار الاتجاه أنه يصير الويبينار بشكل دوري كل 4 أسابيع أو كل شهر، مرة موجه للأخوة الأطباء والزملاء والزميلات الأطباء، والشهر الآخر يكون موجه للجالية العراقية والعربية بصورة عامة في مجال التوعية، وإن شاء الله راح يصدر التواريخ ويعلن عنها في وقتها.
Excellent. Well done. Thank you very much. عاشت الأيادي.
10 ليالي. شكرا دكتور علي، شكرا جزيلا على هذا التقديم الرائع.
دكتور علي ممنونين.
عشتيكم.
شكرا جزيلا.
عشتيكم. عشتيكم.
نتمنى اللقاء
شكرا جزيلا.
ممنونين.
شكرا للحضور.
شكرا دكتور. شكرا دكتور علي.
اهلا وسهلا. شكرا
شكرا جميعا، مشكورين.
عاشت ايدك دكتور علي.
ولا يهمك، عيني في الخدمة.
محاضرة روعة كانت.
الله يسلمك. هسه احنا سجلناها، هاي وين راح تحط على الويب سايت لو وين تنزلها؟
اخليها يوتيوب. شنو اللي انا اقدر اخليها على يوتيوب، اسويها ابلود؟
بتر دكتور، بتر اذا يوتيوب، يا ريت.
ممكن.
Dr. Issam, you still recording. Maybe stop the recording.